Hello. Today, we're going to cut right through the noise and focus on the critical red flags for women's cancers. Think of this as a rapid refresher for busy UK GPs, focusing on those signs we absolutely cannot afford to miss in our surgeries. Let's dive in. This quote from Cancer Research UK really gets to the heart of what we do in primary care, doesn't it? Our role is just so pivotal because spotting something early, it doesn't just improve outcomes, it completely changes a patient's life. Every single consultation is a chance to make that difference. And this number, well, this number really frames our whole discussion. The NHS long-term plan has set a really ambitious goal to diagnose 75% of all cancers at stage 1 or 2 by 2028. And let's be clear, this is a primary care challenge. It lands squarely on our shoulders, and it's one we have to meet. So, here's how we'll break it down. First, we'll quickly cover why early diagnosis is so urgent right now. Then, we'll get into the tricky clinical clues for ovarian and bowel cancer. We'll hit the hard and fast rule for postmenopausal bleeding, get clear on biomarkers, and then wrap it all up with a practical checklist for your practice. Right, Section 1, the early diagnosis imperative. Let's just quickly set the scene. Why is this conversation more important now than ever before? Well, the reality is we're facing a rising number of cancer cases in women, and it's often complicated by those vague, non-specific symptoms we see every single day. On top of that, we know there are inequalities. For example, Black women are more likely to be diagnosed at a later stage. So to navigate all this complexity, we need a reliable guide. And for us, that's the NICE NG12 guideline. It's our essential tool for making the right call at the right time. Okay, let's move on to our first clinical scenario. And it's a classic diagnostic pitfall, isn't it? The vague, almost insidious presentation of ovarian cancer. We all get this, right? The patient comes in complaining of bloating. And the question is, when is it just bloating and when is it something much more sinister? It is so easy to just label it as IBS, but the NICE guidance gives us really clear criteria for when we need to dig a bit deeper. And look at the detail here. NICE tells us to pay very close attention to frequency, symptoms that are happening more than 12 times a month. But here is the absolute clinical pearl, the thing to really take away. Any new IBS-type symptoms in a woman over 50 should always make you think about ovarian cancer, because true IBS rarely, if ever, presents for the first time at that age. And this is the absolute threshold. This is non-negotiable. While the symptoms are what trigger our initial tests, a physical finding is a different ballgame. If your examination finds ascites, or you can feel a pelvic or abdominal mass that isn't obviously a fibroid, that is an immediate 2-week wait referral. There's just no ambiguity there at all. All right, moving on to one of the most clear-cut, black and white red flags in all of general practice. The message here could not be clearer. For a woman aged 55 or over, any vaginal bleeding, and that's bleeding that occurs more than 12 months after her last period, is an urgent 2-week wait referral. End of story. This is an absolute, non-negotiable standard of care. Now for our third scenario. This is one where a really common blood test result can be a subtle but absolutely critical clue for a major gastrointestinal cancer. Unexplained iron deficiency anemia in a postmenopausal woman is a massive red flag for colorectal cancer. Now, this NICE pathway might look a bit complicated at first glance, but it really boils down to this. If her full blood count shows anemia and a low ferritin confirms its iron deficiency, your very next step is to offer a FIT test. This test helps stratify her risk and guides the urgency of her referral for endoscopy. Next up, let's talk about a common pitfall: the use and sometimes misuse of tumor markers in primary care. It's so important we get clear on their role. So, what are we actually talking about when we say tumor markers? Well, they're simply substances we can measure that are associated with cancer. And that word associated is really the key to understanding both their utility and their limitations. And this is why they can be so tricky to use. See, a useful test needs to have high sensitivity. It needs to be good at picking up the disease. But it also needs high specificity. It has to be good at correctly identifying those who don't have it. The problem is most of these serum markers have poor sensitivity for early-stage cancer. And because they're just tumor-associated, they lack specificity. That leads to a lot of false positives. This is why clinical context is and always will be king. Just take CA-125 for ovarian cancer. It can be raised by a whole host of benign conditions, everything from endometriosis to PID, especially in premenopausal women. And this creates two massive dangers: a raised result causing unnecessary alarm, and even worse, a normal result that provides false reassurance in a patient who has clear, persistent symptoms. Okay, let's pull all of this together now into a really practical summary, something you can apply immediately in your surgery tomorrow. So let's lock in these key referral thresholds. For ovarian cancer, persistent symptoms in women over 50 triggers a CA-125 and an ultrasound scan. A palpable mass is an automatic 2-week wait. For endometrial cancer, postmenopausal bleeding in women over 55 is always a 2-week wait. For colorectal, unexplained iron deficiency anemia means you offer a FIT test. For breast, an unexplained lump in a woman over 30 or nipple changes over 50, again, immediate 2-week wait referrals. And finally, and this is so important, never, ever ignore your clinical gut feeling. It is a valid and vital reason for further assessment. So we'll end with this question for you to think about. Based on this quick review, what's the one thing you'll do differently? Maybe it's just lowering your threshold for ordering that CA-125 for persistent bloating. Or maybe it's ensuring every single woman over 55 with postmenopausal bleeding gets that urgent referral without any delay. Because acting on these red flags, that is how we turn that 75% target into a reality for our patients.